epilepsy. Okay, so Journal Club for today. Today is 20th of July, 2023. And today I thought we would cover part of the Journal Club, epilepsy. Let me ask one of you to give me the definition of a seizure. What is the definition of a seizure?
Neuronal firing.
Firing, okay. Yeah. Anybody else?
Too large, simultaneous, abnormal firing of neural
Okay.
brain.
Generally, we say that there is a abnormal electrical discharge of a group of neurons without the appropriate inhibition. The inhibitory component is missing or is abnormal. When I talk to you and I move my hands or I'm thinking, I'm seizing. My brain cells are firing. Fortunately, I have some control over the discharge, because otherwise I'd be falling down and the usual seizure, right? Right. So I thought we would cover the most common type of seizure today that we see. And what is that? What is the most common type of seizure? The what? Okay, focal. What's the other name? Partial.
Generalized
Okay.
tonic-clonic seizure.
Actually, what did you say?
Generalized tonic-clonic seizure.
Okay. From a practical point of view, the most common seizure we see in young people are the myoclonic, so myoclonic epilepsy, myoclonic seizures. And in somebody coming in, let's say a teenager, and they had a seizure first time, second time, usually it's a juvenile, young myoclonic seizure. But what I'd like to do is present the case to you, present one of the patients to you. This was a 17-year-old high school. This is very typical. 17-year-old high school, first seizure. Has tonic-clonic, tonic-clonic seizure lasting a few seconds, usually not more than 30 to 60 seconds. And what else do we see with the seizure? What is that?
Biting of tongues.
Biting of the tongue. And it's very important to recognize that the tongue biting most often occurs on the side, right?
Mm-hmm.
Rather than another type of seizure where it frequently occurs in the front. Like what kind of seizure in an individual where the biting seems to be the front rather than on the side? So which one? No, but what kind? No, there's a type of seizure which is a non-electroencephalographic seizure disorder, right? What kind of seizure is that?
They have like
Well, you can use the word functional, but it's non-electroencephalographic seizure. It's sometimes very difficult to differentiate between that and a regular tonic-clonic seizure. And sometimes the patient has both. So it's very difficult without long-term monitoring, long-term EEG monitoring, usually in the hospital. But I'm very cautious about jumping to that conclusion. But getting back to the regular 17-year-old seizure occurred early in the morning, right? Most seizures occur early in the morning or late at night, getting ready to sleep. And he was getting ready for school. There was no focality to the seizure, no evidence to suggest previous auras. And he'd never had a previous convulsion, the parents said. No family history, right? We asked for family history, no history of head injury, right? We asked about head injury, no history of fevers, febrile, right? Febrile convulsion, another type of seizure. And no history of staring spells, absence, yeah. no birth injury. Always ask about meningitis and encephalitis. This patient, the 17-year-old, when you ask him, he says, yeah, sometimes in the morning I jump. Any of you have that? You jump?
Yeah, that's normal.
Well, how much do you have? You have a lot of it.
No, sometimes.
Yeah, but you see people, maybe you've had friends who jump. That's a myoclonic jerking. This particular 17-year-old had a lot of that jerking. And sometimes it was bilateral, sometimes unilateral. And usually in the morning, it usually occurs in the morning after breakfast. I've had many patients like this. I usually am able to treat them, and over years, they actually get better. I lose them as patients because they get better and they have no more seizures, and I take them off medications. So-called progressive myoclonic seizure disorder. And in this particular 17-year-old, when you ask him, oh yeah, he's had it for a year. And in this particular instance, he didn't sleep at night. So keeping somebody up for a long time can induce a seizure.
Yeah.
Okay, there are certain things that can induce seizures, like staying up at night. Sometimes when you work overnight and you haven't had a good night's rest and so forth.
Sometimes PlayStation can cause something like that.
Gestation,
PlayStation.
PlayStation,
Yeah.
yes. There are a number of
Like
papers that were
yeah.
described from Japan. The Japanese started playing these stations, and they kind of got very much involved in it and had a series of seizures, a whole bunch of
Because
them.
of the flickering lights.
Yeah, flickering, yes. So when he had the first seizure, this particular patient, he was taken to the university, to the hospital emergency room. He was afebrile, blood work was all normal. They did a CAT scan with normal EEG scheduled. And he was given IV medication. What medication should we give somebody? And should we treat the first seizure? Have you thought about
I
that?
think we should first do
Do you think you should wait?
before starting pregnancy.
Okay, you would wait. What about you? George.
I'll find out the cause. Sometimes with hyperglycemia can cause.
Yeah.
Okay, so hypoglycemia is also a trigger.
Yeah.
What do you think, Melissa?
I agree with you. We should really find the reasons cause that. So we're not,
Okay.
we shouldn't really give directly at like medicine.
You said, what about you?
Yeah. I think so.
I should,
You should find out what's the reason.
and I remember that many times, everything's normal. There's no hyperglycemia. There's no abnormalities. EEG is normal, CAT scan normal. Would you treat the first seizure like a classic case of a seizure? No, yes, no. It's controversial. Some people say yes, because there's a high risk.
I think we can.
Some people say to me, they say, the chances of having a second seizure soon after the first seizure is maybe 40%, maybe high.
Mhm.
Person is, let's say, driving a car and then has an accident and so forth. So you could have prevented it by maybe putting the person on an anti-seizure medication. So I think it can go both ways. What I do, I usually base it on the patient. If the patient is positive about being on a medication, I will do it. If the patient says, well, I don't want to be on a medication, I may not do it, but monitor the patient.
Can doctors still ask if they don't give a patient the pill?
That's a
the
good
first time?
question. Every state in the United States has different laws.
Mhm.
And this particular law, is based on state law. In California, for example, you wouldn't think this, but in California, the doctors have to report the patient
Mhm.
to the DMV, to the motor vehicle. And in some states, you're obligated to report the patient. I personally don't like that. I'm generally not for any mandates. I'm against the government stepping in and forcing us. But for California, they do that. Anyways, I'm kind of surprised. Every state is different. And I have in the Woodbridge office, I have a big sheet with every state, like how long
Or
they can't
epilepsy,
drive,
yeah.
epilepsy, etc. But Kenya Sue, I had a patient about 18 years ago. He was from Vietnam. I got to like him, really nice guy. He was the owner of a bar, a bar, like a
Mhm.
bar. I knew he was an alcoholic. I knew he drank all the time. I met his wife, kids. But he was really nice. He was like a happy alcoholic. I told him, you must not drink. You have to cut down the alcohol. I put him on, he was on Dilantin. But many times he forgot to take his pills.
Hmm.
So one day I had this police come in, and big insurance companies sent me letters. He was driving
Pardon me, Jack, may I have your phone, please?
and he had a seizure while he was driving. And so he was seizing and he was driving, and he went up on the corner of a house, and he went up right up all the way up, and there was these two elderly folks having dinner. It's kind of like 8 o'clock at night, and he went on the grass, and he went in and he hit the house with his car and then stopped. He had a generalized convulsion. Well, it cost about $300,000 for the house, the destruction of the house. He almost killed these people. And of course, the lawyers came after me and the insurance company, but fortunately I had documented that how many times I've talked to him, and he was supposed to be on medicines anyway. So the best thing you can do as a doctor is make sure you document these things,
Mhm.
not just tell him, well, you shouldn't drive or you should take your medicines. Some patients will continue to drive and drink and take their medicine, not take their medicine, and have an accident. And the answer is, yeah, you could be liable. And in this particular instance, the insurance company hired the lawyers to come after me, and thinking maybe I can pay the part of the $300,000. Fortunately, nothing happened. The patient didn't come back right away, but 6 years later, I saw him again, and he came in and he thought I'd forgotten. But no, I didn't forget, and he was kind of laughing. I'm sorry, I'm sorry, but he did come back. And I haven't seen him now for quite a while, so I'm not sure what happened. He was one of these nice people, likable, but would get you into trouble. So the answer, good question. Always assume that you can be liable. So one of the reasons I like to put these patients on some coverage, anti-epileptic coverage, one of the reasons is because of this. So I encourage the patient to get on something. I said, well, it's like an insurance. It's not guaranteed that it's going to stop your seizure, but at least we're doing what a reasonable doctor would do. I've had people fight me on it. Oh, I don't want any medicines. How do you know it was a seizure? And then I kind of pull back a little bit.
Yeah, and when are we going to discontinue the medication?
Well, that's a whole other issue of, I usually wait a few years with no seizures,
Mhm.
and I'm very gingerly, gradually discontinue that. Again, it depends on the type of seizures, family history of seizures, many factors. But you got to be very cautious, and you have to document what you're doing. So let me go on. The patient, normal exam. They gave him phenytoin and a prescription, but the patient and the parents decided not to start the medication. Okay, so he left the emergency room, and he was referred to a neurologist, and that's frequently what happens. They leave the emergency room and they see me. So this particular teenager has the classic juvenile myoclonic epilepsy. The treatments frequently may be lifelong, and only certain anti-seizure medications are effective. And these were reported in the 1980s. So these are the characteristics. It's idiopathic, What does that mean, idiopathic? Anybody know?
We don't know that.
The one?
We
You
don't
don't know what problem.
Okay. Some doctors have referred to it as the doctor is an idiot and the patient is pathetic. You know, it's a sad, so it's kind of a sad thing, but it's true that we're not sure what's causing it. And it does present in teenage years. And it's generalized, it's both hands and both arms rather than one. There's a genetic predisposition. And there's no deficits seen. Sometimes they have neuropsychiatric symptoms. Neuroimaging is normal. EEG can pick up. What does the EEG show if you have juvenile myoclonic epilepsy? What is the sine qua non? What is the representation of the EEG? EEG is an electroencephalogram.
Mhm.
So when you have bilateral jerking, what do you expect to see on the EEG?
Distortion.
Spike.
Spike.
Bilateral,
Spike and wave.
bilateral spike. And these are unmedicated patients. The provocative, alcohol is provocative. Sleep deprivation is provocative.
Yeah.
And photic stimulation, you mentioned photic stimulation, George. It's very well controlled, 80% well controlled with anti-epileptic drugs. And, you know, we usually use it for as long as the patient has symptoms. Rarely there may be unilateral jerks, but mostly in my experience, it's bilateral. And usually they have generalized tonic-clonic activity. And 30% of patients with the juvenile myoclonic epilepsy may have epsons.
Mhm.
So epsons can come together with it. So this brings us to the point of how can we divide epilepsy into groups? One group, one simple way of thinking about epilepsy is one is some kind of genetic, right, inherited condition, and where you have generalized epilepsy, and it's called primary generalized epilepsy. So I think of it this way: primary generalized is a whole group of types of seizures under primary generalized epilepsy. And then you have the secondary seizure disorder, which is another group.
Yeah.
What are the groups in the primary generalized? The most common is this one, myoclonic. But what else? Epsons is another one, which is genetic, the genetic condition. Sometimes could be atonic. You can have these drop attacks, atopic, atonic, myoclonic. Okay, and then partial. Generally, when you have a secondary generalization, usually those are acquired, partial, and not so much genetic. And the EEG in unmedicated patients, they show the bursts, spike and wave, usually bilateral, polyspike sometimes, sometimes spike wave pattern. In epsons, what do we see classically? What?
3 spikes.
3 per second spike and wave is a classic EEG. But remember that many patients with epsons may have 2.5, may have 4, not quite 3, so 3.5. And then sometimes you can have photic stimulation trigger myoclonic discharge and myoclonus jerks. And it's very dangerous because you can induce generalized seizure, right? So you can go with somebody who's stable, then you do photic stimulation, and you can get a generalized tonic-clonic seizure. And the problem is that if you do just a routine EEG, maybe normal, many times we can't get the patient to fall asleep. So we have mostly awake and briefly drowsy EEG. In those cases, I usually recommend getting 24-hour EEG or 48-hour, 72-hour EEG. Gives me a larger chance of picking up an abnormality of EEG. Now, what are the pitfalls of diagnosis of juvenile myoclonic epilepsy? And it's misunderstood, the myoclonic jerks, because they may represent focal jerks. The jerks can be asymmetric. It could be on one side. There's a misdiagnosis. Sometimes the patient is diagnosed as partial seizure with secondary generalization. And many medications are used, of course, in these. And there is a progressive myoclonic epilepsy, for example, Lafora body disease or Lundberg disease, genetic diseases. And so you need to kind of be aware of it. Now, there's the older anti-epileptic treatments. These were valproic acid. What are the problems with valproic acid? Well, it's metabolized in the liver, weight gain. Females, don't put them on Depakote. They gain weight. There may be a hair problem, and it shouldn't be used in pregnancy. So there are issues with it. Primidone, have you heard of primidone or myceline?
That's also used for essential drug.
Yes, it's a very good medication for tremor. Phenobarbital we used in the past. We almost never use phenobarbital because it's addicting. It has a long half-life. Phenobarbital may have a 3-day half-life, very long half-life. And Klonopin is another one that we've used. What are the newer agents that we're using for, primary juvenile myoclonic epilepsy? Keppra, yeah. What else? Yeah, lamotrigine. It seems to be a very good medicine, and levetiracetam, as you said. Topiramate, Topomax has been used. I don't really like it for seizures. I use it for headache.
Makes drowsy.
Yeah, and zonisamide. I like to use zonisamide as well. Zonisamide is very popular in Japan.
Is that the name? So,
The one?
is that the brand name or the name?
Yeah, this is the generic name, zonisamide. And we tend to use it. Many of these kids are in school, and you have to be careful about seizure treatment because of cognitive changes, sleepiness, and there's little sex predominance, and there's no, everybody gets it. If you're white, black, brown, you get it. Male, female, you get it. So the juvenile myoclonic epilepsy is very common, and we'll be seeing these while you're here cognitively. If the patient is older than 10 years of age, when we first say it on monotherapy, the risk of hepatotoxicity with Depakote is less than 1 in 500,000 patients. Pancreatitis is another rare. Other side effects include dose-related tremor. As you increase the dose, the tremor may get worse. Thrombocytopenia with low platelets, weight gain, and hair loss frequently. And so that's important to know. The alternative medicines we talked about. And I had a picture for you here. And I wanted to see what you thought about it. As a side effect when you're treating patients with epilepsy. And I wanted to show you this picture here. Can anybody recognize this picture? This is a patient with treatment for epilepsy. Could be any of the medications. What do you see here?
Stress.
No,
in,
how much,
Mild.
do you remember your dermatology? The who?
Yeah.
Well, there is an eosinophilic condition that you get with allergies, but this is very, very straightforward. What are the skin? When you have a manifestation of medication,
That's the treatment cause that or pain.
lamotrigine, of course, can cause severe skin. But you've never seen this before?
You mean like
These are bullous lesions in the hand,
Johnson?
everywhere, huh?
Stephen Johnson?
Stephen Johnson, yeah. So this is what you get. It's called Stephen Johnson, it's very common. Now, some patients can die from it, so it's serious. And I'm always worried about lamotrigine as one of the agents, but it can be with almost any anticonvulsant. So you got to bring the patient back, make sure they call you. How are you doing with the medications, any side effects, etc. Very important to kind of remember. Let's see. The absence we've talked about a little bit. I wanted to kind of just touch bases on a subject that's very important in epilepsy. And I think it's very important to talk to the patients, young teenagers or older teenagers or people who live by themselves. It's called SUDAP. How many of you have heard of SUDAP? Unfortunately, I've had almost every year, I lose one or two patients to SUDAP. Sudden death in epilepsy, SUDAP. Sudden, and it's usually unexplained, unexplained death in epilepsy. And we've changed the attitude about it. In the past, we never mentioned it to patients. It's uncomfortable, right, to mention it. I try very hard to get my single patients to have relationships, so at least they're living with somebody. You'll find me frequently asking, well, do you have a girlfriend or a boyfriend? Unfortunately, when you really recognize it when you lose a patient, especially somebody that you really liked and cared about, they always seem to be young. They're either old teenagers or young 20s or something like that. And I usually attend the funerals, so when you don't see me here, I'm at a funeral of one of my patients. So SUDAP is important, right? It's unexpected, it's sudden, unexpected.
How common?
It's fairly common, and I have a number of papers here for you. And it's been recognized for centuries. It's been around a long time. And it's totally unexpected. Now they say that there's a risk of 1 in 370 patient treatment years. 1 in 370 to 1 in 1,000 patient years. So there are many people, and they're associated with certain medications. And there's a strong association of SUDAP with Tegretol. Have you heard of carbamazepine?
Yeah.
There is an association, and there's an association with living or sleeping alone. So I try both. I take people off carbamazepine. I try, and I also want them to have somebody else to be there.
What can that person do for the person who has that? What can the other person do to save the other person?
Well, because we don't know. Frequently, the SUDAP patient is found in the bed with their head down, sometimes in the pillow. Sometimes they're underneath the cover. We're not sure exactly what causes it. Is it maybe a cardiac arrhythmia? Is it some dysautonomia?
Yeah, how could the other person save the person who has SUDAP?
Because when you're next to the person and you feel somebody seizing, you take care. Maybe you move the patient to the side, You stimulate them to see if they will wake up, what have you. Having somebody there is protective. And if you're interested in the subject, people have studied this. They did post-mortem changes in blood concentration of phenytoin and carbamazepine using rabbits, for example. They found more commonly that the carbamazepine is involved in the SUDAP death. They looked at population and they looked at a whole population for SUDAP. The rate was generally 45% before 1950, and it's now 40% since 1984. And of course, not everybody has an autopsy, and they did a study here at Mayo Clinic. So the urban community has experienced a population increase from approximately 25,000 in 1940 to approximately 71,000 in 1990. 95% of the population receives some or all of their care at the Mayo Clinic. Each year, more than half of the population seen. All autopsies in the community, including those under the jurisdiction of the coroner, are performed by pathologists from Mayo Clinic. The annual autopsy rate in the community varied and so forth. So this data is very good. The Mayo Clinic data is probably the best in the world. And you want to read more about it, you can read it. And they had almost 300 patients who had SUDAP, and they write down the ages and, you know.
How did
What?
Mayo Clinic get so influential?
Why? I'll tell you why. One of the reasons is it's in a small community called Rochester, and it's very homogeneous. And that population has been studied for everything: heart disease, blood pressure, for everything. And it's really a small community. It's really excellent. You're doing epidemiologic studies. I was invited out there, and I really liked it. I liked all the places I went, but I went there in wintertime. Wintertime, it's very cold. It's in Minnesota. You got lots of snow, and there's not much to do. I would recommend that you go as a married person. I mean, there's not much activity. There are St. Mary's and a couple of other hospitals, big hospitals in the area. And there's a lot of little coffee houses, and it's really a very pleasant, charming place. It's the only Rochester, Minnesota is the only city where when you land, there's a whole bunch of wheelchairs. It's like they're lined up. Well, the wheelchairs are lined up for patients coming in. But they have very good data. When you look at the Mayo Clinic data, the statistical analysis and the epidemiologic studies, excellent. The sometimes, for example, here is a temporal lobe complex partial seizure. This is by Locatelli. Association between left temporal lobe, specifically left temporal lobe seizure, and cardiac asystole. For some reason, the left temporal lobe discharges are associated with asystole, cardiac asystole. So remember, I said that it could be dysautonomia, and they wrote about 3 patients, reviewed the literature, 10 reports, and they actually show the electroencephalogram and the EKG at the same time. It's excellent. So during the process, like a seizure, you can diverse physiologic effects without simultaneous respiratory monitoring to establish the presence of affected gas exchange, et cetera. So they kind of criticize it. But I like this idea that sometimes there is a 10-second cardiac pause during one of these seizures. So And Dr. Gilles Minot from California wrote a paper in it, sleep. Sometimes it's associated with sleep apnea or sleep disease as well. We don't have the answer, but it's something that what I've started doing is mentioning it to my patients. In the past, I didn't mention it, but now I kind of, you have to find the right time to mention it to a teenager, like 20-year-old, essentially. But I've lost too many, even losing a single patient to SUDEP, it really hits you. You never forget it. And it's happened to me. I have a picture of one of my patients on the board, Alexandria office. If you remind me tomorrow, I'll show it to you. I was at his funeral. I took care of him for almost 10 years. And he was living at home with parents. And he still died suddenly in bed. He was found dead in bed.
So
He suspected.
what was the, what was
Well, this is what I'm saying, that we don't know for sure whether the head, when you have a seizure, the head goes into the pillow and you stop breathing. You can imagine that, you stop breathing. Or other possibilities include, they also have sleep issues. They also may have cardiac arrhythmia where the heart goes into ventricular fibrillation. So, I mean, there are many possibilities. We still don't know exactly the cause.
So when the patient dies from SUDEP.
Yeah.
If we dissect him.
They get an autopsy.
Yeah, we do the autopsy.
Yes.
What's gonna be the answer to the, what was the death? What are they gonna write?
Well, you try to,
Stuff.
you try to look at everything. It says the incidence of SUDEP in the study was 0.35 per 1,000 person years. It's measured in person years. It's very low, like 0.35, right? So it's like 1 per 3,000 person years. Okay, SUDEP is responsible 1.7% of the deaths in the cohort of seizure patient. Very low, 1.7%. So this is a rare cause of death in epilepsy, but exceeds the expected rate of sudden death in general population by 24 times. It's 24 times more frequent than death in the general population, patients who don't have seizures, we think. The reason I bring it up is it affected me emotionally. When you lose somebody that, you've taken care of for a number of years and they had problems and you overcame the problems, middle school and then high school, and they finished high school and they were going to get a job and the parents are there, et cetera, and then suddenly the person's dead. It really hits you. So SUDEP, I recommend that in a nice way, you talk to the patients, the parents frequently. If they're single, I would like them to find a partner. These are frequently people in their 20s, maybe 30s, early 30s. But that's all I can do. I try not to put them on carbamazepine or Decretol. Avoid alcohol, avoid triggers,
Also, when the patients have seizures, the brain gets swollen.
That's true too. So you get some
Maybe that-
swelling, you get maybe secondary effects. Maybe stop breathing. You become hypoxic. So a little bit of hypoxia, and then the head is, let's say, in the pillow or twisted or something. Or have you seen patients with SUDEP?
No.
You haven't. You will. So anyways, I just wanted to, yes.
You're 2:30.
Okay. Anyway, that's it for today, a little bit, just to cover a little bit of epilepsy. Some of the issues that we haven't talked about. Okay, thank you, Dr. Stein.
Welcome, thank you.
Yeah, this is again, myoclonic epilepsy, if you want to read more about it.
Who's next?